Hi, this is Don Sharp with OBR, and we are here today for another webinar brought to us by Kantar Health and OBR, this one titled Patient Affordability, the Ongoing Crisis. I assume everybody on the line here today is involved in the cancer industry in one way or another, and I think if you are involved in it, you can understand patient affordability is certainly being portrayed as a crisis regardless of what your role is, healthcare provider, the payer group, and certainly if you're a patient or know somebody who's a patient. The cost of cancer care is certainly can be described as an ongoing crisis at this point. We're here today. We're going to spend the next hour with you. Very excited about the topic and very excited about our panel members. As you see, we've assembled some great people here with information, terrific resources that we can tap into. In other words, I'm going to introduce them. They're going to talk about their perspective on the ongoing crisis and patient affordability. And you'll have the opportunity to ask questions and through your chat box. I'm assuming everybody understands, click in the chat box and type away. We have a team of people that are here to triage questions, and I'm the moderator today, so I'll be asking the questions of the panel as they come in. So please, by all means, feel free to participate and interact with our panel as we go. And we're going to leave some empty time at the end of the webinar for Q&A also. So today we have Debbie Warner. She's Vice President of Commercial Planning at Kantar Health. Hello, Debbie.
Hello.
Debbie, you're there. Just want to make sure you're there. Lynn Humphrey, Practice Manager at Cancer Center of Santa Barbara. Lynn, you with us?
Lynn, you might be on mute.
I am
Hello,
here,
Lynn.
Don. Good morning.
Okay, good. And Trishs Goldsmith, Chief Executive Officer of Cancer Care. Trish, you're here today too.
Good afternoon, Don. I am.
Excellent. We're going to get into their backgrounds a little bit further as we get into the presentations. I'm going to first begin, though, by pointing out some of the things that we're going to try to do today, gain an understanding of how deep this crisis is, looking at the escalating costs of cancer care, and the scale of that problem in cancer care today. We'll define programs that patients need for financial assistance and how they can access those programs. Hopefully get a firsthand, that's why we have a practice manager here, appreciation for how practices are dealing with the cost of cancer care and the services they provide to these patients. And as we mentioned, it's a crisis, so I'm sure we're going to hear how this crisis is impacting prescribing decisions today, and also talk about how manufacturers can provide value and what further assistance they can offer. So Debbie, I'm going to ask you to jump on first. Can you tell us a little bit about what you do at Kantar Health first, please?
Certainly, Don. I lead the Oncology Commercial Strategies practice here at Kantar Health, and we produce Oncology Market Access, which is a syndicated subscription service based on a breadth of market research that covers market access in oncology in really the broadest sense of the word. And I'll be sharing with you today just a very small bit of the information and insights that we gather as part of that.
Great. And, I do have a slide up here talking about the scope of this problem. And you can see here, financial toxicity, a lot of media coverage of the cost of cancer care, 60 minutes. And then, Debbie, if you would, I'd ask you to take it away, please.
Great, thank you. So certainly as a function of cost and affordability, it's really changing the complexion of treatment decision making. And as part of the coverage in our OMA, we've been following patient affordability for the last 4 years in our surveys that go out to practice managers, physicians, and patients as well. So the data I'll be sharing with you comes from all three of those, and I'll be doing a little bit of bouncing back and forth between oncologist perspectives or patient perspectives. So treatment decisions today, besides the expected efficacy and safety, are also colored by questions such as, is the payer going to cover my treatment, and to what extent? How's it going to impact quality of life? And is the treatment affordable? A key question not just for the patient, but for the physician as well. And a question that patients are pondering more and more is the benefit worth the price and the cost? And physicians are even considering that question as well. And one of the things that we found in our research with oncologists and practice managers is that they are doing a number of things to respond to patient concerns about cost. Certainly half of the time they're helping patients with financing. So what this is showing is what percent of the time are you doing these things when patients raise cost concerns. But around a third of the time, oncologists are actually adapting the treatment plan. And nearly a quarter of the time, they're using less costly drug options. So clear evidence that this is changing, impacting prescribing at the point of care. But what we
Debbie,
also...
I'll just ask too, Debbie, can I just ask, when was this survey performed?
Oh, thank you. This survey was performed April through July of this year, depending upon which of the groups. So we began April, May with oncologists and practice managers. June, July were patients.
Yeah. So any changes in prescribing habits it's very current and recent.
Exactly. Thank you. So besides at the point of care decision making, what we also learned is that practices are factoring treatment costs more broadly into what they do. So building up practice capabilities to help find financing. 3/4 of the practices told us that. But oncologists, 58% of oncologists are considering alternate treatment regimens. They are looking at, they're referring to other sites of care. And even more interestingly, it's impacting their preferred treatment regimens. And for practices that have established their own pathways, they're even adapting their pathways in response to their experience with patient cost. So some of you may be familiar with this somewhat landmark study that was done back in 2011, and it provided very strong empirical evidence that out-of-pocket cost does clearly lead to prescription abandonment. So what you're seeing here is the percent of prescriptions, and this was for the collective oral oncology drugs at the time that included Tarceva, Gleevec, Sutent, Nexavar, Revlimid, and Tykerb. And you can see that prescription abandonment was fairly low, about the typical, at when the cost was under $100. It edged up just a little bit until you get to the $300 to $500 range. And then you can see a fairly dramatic leap in prescriptions that were not filled at the pharmacy. The other thing that I'll point out is this is the number of patients that were in each of these groups, and a quarter of all of the patients had an out-of-pocket cost at this time over $150. We know out-of-pocket costs have risen since then. And I'll also point out that the largest group certainly has relatively low out-of-pocket costs, but the next largest group, and considerably larger than any of the others, are patients with out-of-pocket costs over $500.
And these are 2011 numbers.
Those were 2011 numbers. This study has not been repeated. and this was a study that was published in the American Journal of Managed Care. We did not do this research. It was done by an academic institution. Okay. So what Kantar Health has been doing each year in our patient surveys is to take quantitative measures of patient cost sensitivity and how their cost sensitivity stacks up against the impact of the efficacy of the drug, side effects, and quality of life. What we do is we conduct a classic conjoint exercise. So patients see cards that randomly provide them with a view of a survival rate that may be the shortest, moderate, or high, side effects, quality of life, and patient out-of-pocket cost. What I've shown you here are general, just a kind of a generalized view, but in the product profiles that patients saw, and we looked at patients with breast cancer, non-small cell lung cancer, and non-Hodgkin's lymphoma, they saw very specific and detailed product descriptions with survival rates and adverse events that are associated with the common drugs to treat those diseases. The out-of-pocket costs that were varied was, in the worst case scenario, they saw an out-of-pocket cost that was $500 per treatment, essentially comparable to the catastrophic out-of-pocket cost for a patient with Medicare on a high-cost oral drug, or $250 per payment, where you might see a specialty out-of-pocket limit, or $25 per treatment. And what we found from this is that, in fact, the out-of-pocket cost had a substantial impact on the likelihood that a patient would fill their prescription. So let me take just a minute and explain to you what it is you're looking at here. So the line, first off, we're showing data from, this line represents, at the best case scenario, the probability that patients with breast cancer would fill a prescription that decreased pain, had the highest survival rate, mild side effects, and an out-of-pocket cost under $1,000. With that kind of product profile, 70% of breast cancer patients would take the medication, 77% of non-small cell lung cancer patients would, and 72% of multiple myeloma patients would. This happened to be an oral product profile. We did the same with an IV product profile, but in the interest of time, I'm just showing you oral. The IV was similar. So if the line represents the base case, each of these bars show what the resulting probability of actually filling the prescription was if, for example, if it was the best case except the out-of-pocket cost was $6,000 instead of less than $1,000, the probability of the patient taking the drug dropped from 70% to 41%. That is comparable or slightly greater even than if the drug was under $1,000 per month, but it had the smallest survival rate. And in the case of breast cancer, that was a 2-month incremental difference. So you can see that the out-of-pocket cost was comparable in importance to survival. And for that matter, even an out-of-pocket cost of $3,000 had a greater impact than, say, severe side effects. And looking across at these other disease states, relatively speaking, the impact was the same. So it is fairly it's fairly universal, though from a cancer type to cancer type, we do find some interesting differences in terms of what patients are actually willing to tolerate.
Debbie, I think you did a real good job explaining that slide, and I just want to remind everybody if you have any questions. One of the questions was, do we have data on IV drugs? So I think we've answered that. There's, because you mentioned that in your explanation. And so I just wanted to put that up there for a second and note that, the N is 60 in each of these two, so people can see that. But, want to remind everybody you can easily type in a question every question.
Yeah.
Okay,
great,
go ahead.
Thanks. Also, I'll note there is a little bit of inherent selection bias in a web-based survey, so you tend to get patients that are somewhat better educated with somewhat higher incomes, and we also have a little bit less Medicare representation in this study than you see in the general cancer population. But among the patients that participated in our study, nearly half of them told us that they experienced financial challenges during the course of their cancer treatment. But interestingly and somewhat distressingly, when we asked about when did they actually have a conversation about affordability, about financial issues, what we found was that as much as at least 40% to over a half of the patients didn't discuss costs with, and affordability with anybody in the practice. So, this is a key issue that suggests the importance of making sure that the practices are well aware of the support programs that are available. When patients did have financial challenges, we asked them what happened, what did the practice do? And here you're looking at what the practice did, broken out as a function of the type of insurance the patient had versus the type of cancer. And what you can see is that in terms of someone in the oncologist's office suggesting financial assistance, that was very common for patients with Medicare, but it was less common for patients with commercial or health exchange insurance. Those patients tended to be likely to be able to stay on their therapy without making changes, whereas most of the Medicare patients needed to actually seek the financial assistance.
And that answers, I think, one of the questions about payer and the difference between those groups. So I just wanted to point that out. Go ahead, Debbie.
Yeah. So we asked the practice managers about what is the insurance breakdown of patients who you refer to assistance programs. And you're looking at a comparison between the data from 2013 and the data from 2014. And what you'll see is that the Medicare, the combination of different forms of Medicare, whether Advantage or fee-for-service, with or without Medigap, accounts for the lion's share, nearly half of these patients. Commercially insured patients have really jumped up significantly in terms of the proportion of patients that are getting referred for financial assistance. And I think that this is really a testament to what we've been hearing and following, which is that there's increasing cost shifting to patients in terms of the percent co-insurance, the dollar costs of co-pays, lifting or removal of caps in total out-of-pocket cost. So clearly, assistance programs are really critical to help ensure patients get the medications they need, to help ensure that they don't have to opt for a lower cost, a less preferred option, or go elsewhere for their therapy. And we asked practice managers about what kinds of things make it more challenging for you to get assistance for patients. And certainly unchanging from prior years, eligibility requirements is really the key. When eligibility requirements are difficult to meet, that's the number one or number two challenge for half of these folks. Inadequate funding has dropped as an issue, suggesting that there are more contributions to funds available and greater availability on the commercial side. Another issue that came up as the second most common is when the program applies only to the pharmacy benefit, but not to drugs that are administered by the office. So really important to keep in mind the kinds of things that make programs challenging so that they can be as easy as possible for practices to take advantage of. And you'll be hearing more about that from Lynn and Trish. So just in wrapping up really quickly, hopefully you've gotten these 5 key points out of this. Patient affordability is one of the leading non-clinical attribute that impacts oncologists' decision to select one therapeutic agent over another. The practice staff play an absolutely critical role in helping to prevent prescription abandonment through the discussions, and it's important to be able to support those by minimizing the burden that practices have to bear in being able to get patients to the assistance they need. And a well-designed, well-funded program is going to help enable the physician and the patient really stay focused on the clinical value of your products. But also important is even with financial assistance, patients are bearing a higher and higher cost. And we have found in other research that we've done that there is a willingness, not just ability to pay, difference that comes into play. So it's really critical that you're able to convey directly and through the oncologist what the value of the product is, and convey that it is worth it for the patient to to go on to a medication that may cost them more, but offers them greater value. So with that,
I was just going to ask you a couple quick ones. Just one of the questions, I think, with the AJMC study, the out-of-pocket costs were monthly versus your study where the out-of-pocket costs were measured annually, I believe, correct?
No, well, we presented it as this is how much per treatment, so per course of therapy, so it was monthly, and then so the overall total cost of therapy, and what we did was we multiplied that times what a typical duration of therapy is for patients. Right. So they saw it both ways.
I think we can assume that in the case of oral cancer drugs and Medicare patients, once they get through the donut hole, the drop-off rate decreases, correct?
No, actually, I would say that's not correct. Case in point, the $500 is where the drop-off was the greatest. And once the patient's through the donut hole, they still have responsibility for 5% of the total cost of the drug, and there is no cap or limitation on that. So for a drug that's $7,000 or $8,000 per month, you're still looking at anywhere from $350 to $400, even $500 per month in out-of-pocket costs that the patient still has to bear.
And then last one I just asked real quick, there wasn't any income stratification in your study?
We have the income breakdown in our demographic data, and we can look at it that way, but we did not recruit to particular goals. So it's not; these aren't income-adjusted numbers.
Okay. So next up, Lynn Humphrey, Practice Administrator, Cancer Center of Santa Barbara. Lynn, thank you for joining us today. Can you give us a little bit of information about your practice, roughly how many physicians, how many patients you see? Is it all kinds of tumor types? And how long have you been working in the practice, may I ask?
Sure, Don. Thank you. I've been here for 9 years, and prior to that, worked exclusively in the managed care arena, and most recently as Vice President of Sales and Marketing for a managed care firm in New York. Today, as practice administrator, I'm providing administrative oversight to the practice, including financial analysis and reporting, practice productivity, budgeting, billing, and financial counseling. So it's a very different environment in which I'm working today. So
roughly what size is the practice, just to get a feel for that?
This next slide will show us the size of the practice. Are you seeing that?
Oh, yeah, not yet. So
I wonder why.
Here we go.
There you go. You see it now.
And then, Lynn, before you start, I just want to ask you, according to Debbie, 40% of patients don't discuss the financial considerations with the practice. Would you say that's true? Is that what you see?
Well, it's certainly not our experience, fortunately, and it's dismaying to hear those percentages, because it's such a critical component of what we can do to help the patient as they go through this process. With the initial diagnosis, so many patients are just in a totally different environment from anything they've ever experienced before. They're frightened and they're unsure about what's going to happen to them. And if we can relieve that one concern and let them know that we're going to be there to help them finance the care that they need, it goes a long way to making them feel slightly more comfortable as they go through the process.
Right. Okay.
So on this slide, you're seeing some information about our practice, some of the specifics, and what an average month looks like in terms of care. You'll also notice that the mission statement of the Cancer Center is to provide cancer care to all patients in Santa Barbara County, regardless of their ability to pay. So having made that commitment, we feel a responsibility to help our patients find resources to pay for the care. Now, the work that you see here is supported by a team of social workers, support staff, and they're all working to help our patients find sources of financial assistance. So, the question has arisen, well, why is financial assistance so important today? And, we know that employers are looking to reduce their health care costs, so we're seeing higher deductibles, co-insurances, maximum out-of-pocket limits, and at the same time, fewer benefits. In addition to that, employees are shouldering a larger percentage of monthly premiums. So in looking at those programs provided by employers, we've seen that 18% of those plans have an annual deductible of $2,000 or more, and that's for single coverage, and that represents an increase of 15% over the past 8 years. 32% of non-Medicare adults are having difficulty meeting medical expenses, and 11% are unable to pay those costs at all. So close to half of insured patients are struggling financially with the cost of their care. Now, Medicare enrollees, 50% have an annual per capita income that's less than $22,000 and savings less than $53,000. And next year, Medicare enrollment is going to reach almost 56 million, and by the year 2030, we're looking at over 81 million Medicare beneficiaries. So these changes, amongst others, are really forcing everyone in healthcare, and particularly in oncology, where costs are increasing exponentially, to focus our attention and also focus our resources on helping patients to not only get the care that they need, but assist them in finding ways to pay for that care. The next slide is not advancing. Don, can you advance it for me?
I did. I went one too far. Here we go.
There you go, patient-payer demographics. So currently, we have 57% of our patients enrolled in Medicare, and 13% of those are Medicare only or covered by a senior plan that replicates Medicare. The Medicare population in our practice has grown steadily over the past few years, while the uninsured population has declined with the advent of the Affordable Care Act. Also impacted by ACA has been our Medicaid and commercial populations, as newly insured individuals are finding their way into the system. 37% of our patients have commercial coverage, and we're, of course, seeing patients with and without secondary coverage. Now, I think traditionally we've thought of patients with commercial coverage as being able to manage the cost of their health care, and yet increasingly we're hearing from this population that they have concerns about being able to afford care as prescribed by their physician, and sometimes that necessitates a change in treatment. We're treating Medicaid patients, Medi-Cal patients if you live here in California, and some of these patients have a share of cost. So even though the Medicaid or Medi-Cal system has determined that they can pay a share of their costs, they oftentimes have difficulty, and we need to help them find assistance to meet those expenses as well. So all in all, the challenges surrounding the cost of care, with drugs being the driver, has really become the hallmark of cancer care and doesn't seem to be limited to patients in any one payer demographic. So some of the ways in which we help are to work with uninsured patients, and we're enrolling them in the insurance exchange plans, or we're enrolling them in Medicaid or Medi-Cal programs. We help them to apply for Social Security and disability benefits, and we also enroll them for free drug coverage. So the staff is working diligently to find other sources of support, and we oftentimes go to national foundations, pharmaceutical companies to access copay assistance programs for our patients, as well as free drug programs. And free drugs can be either a quick start type program when a patient has just initiated treatment, or the free drugs can be provided for the duration of the patient's treatment. We also look to local philanthropic organizations, and in our case, the Cancer Center has a charity care program that's funded by donations. Let me go back one. Yeah, support. So the support staff has found some additional sources of funding, and we're covering things for them such as transportation costs, which allows them to get to their appointments, and that can be in the form of a gas card, or we're actually paying for taxi rides. We help patients meet their obligations for rent. We help them pay for food, also help them with child care costs. And we've been able to identify foundations that will pay monthly insurance premiums, and thereby giving patients broader coverage than they would have otherwise. We work with copay card programs that are sponsored by pharma, and these are for patients with commercial coverage. So right now we have 13 IV drugs that have copay card programs, and for those patients enrolled in the programs, 96% of their costs are being covered. So those programs are very important to our practice. So we look at all chemo orders as the patient has received their diagnosis and they're being scheduled for treatment. And we're looking for patients who qualify for assistance, as well as drugs that will qualify for assistance. Now, patients on oral medications require greater vigilance from our staff because we don't always know when those patients have been prescribed an oral medication. Retail pharmacies, as we know, don't necessarily inform patients of assistance programs, so it's really up to us to make sure that patients are educated and enrolled into these programs. And this is considerably easier for practices that have in-house dispensing pharmacies, and more challenging when the patient actually goes to the local pharmacy to pick up their prescription. So oral drugs, there are certainly a lot of benefits to oral drugs, the targeted therapies that are typically resulting in better outcomes and increased survivorship for patients, and there's a patient convenience factor as well. They can avoid trips to the office, time spent in the chemo chair, and if they're still working, they can, we'll see less absenteeism for them. And so those are all benefits to the patient. But having said that, there are certainly some issues, and not the least of which is the cost. And oral drugs, the average out-of-pocket expense for a patient is $25,000 right now. Now, if this were IV therapy, the drug would be covered under Part B, or the medical benefit of a commercial plan. There'd be a deductible involved, a flat copay typically could be $20 to $50 per treatment. But the key factor here is that in these programs, there's a maximum out-of-pocket that the patient is responsible for, so a limit to the cost sharing. When the patient is taking an oral, that drug is typically going to fall under Part D or the pharmacy benefit coverage of a commercial plan. These have separate deductibles. Typically, the patient can pay a percentage that's as high as 50% in plans with specialty tiers, and there's no limit on out-of-pocket expense. So just to bring this into focus, we can see a patient that has a copay for an oral drug of $3,200 a month for one drug, versus if that drug had been covered under the medical benefit or Part B, there would be a maximum out-of-pocket. So it's very, very different in terms of how those programs are structured. Some of the other concerns with oral drugs, the drugs are sometimes poorly tolerated, and that can lead to the patient experiencing side effects and toxicities. That can lead to noncompliance. Other factors impacting noncompliance can be patients splitting their pills to save money, not filling their prescriptions, as Debbie mentioned, because of the cost to the patient. And we've seen that patients taking drugs for chronic conditions will, over time, consistently be less successful in following the prescribed therapy. Care management with oral drugs is another concern, because if the patient is being less frequently monitored by the physician, and that care is oftentimes shifted to a caretaker who isn't as knowledgeable about some of the things that they need to look out for. All of these factors can contribute to the cost dynamic, with a potential for more frequent trips to the emergency room and more frequent hospitalizations for these patients. Now, the oncology drug parity laws have leveled the playing field for patients taking orals in the states where those laws have been passed. And certainly this has benefited many, many patients. The downside, however, is that the law has shifted the cost back to the payers, and ultimately the consumers will pay the larger health care premiums to cover costs that were previously being paid by patients.
Lynn, I thought you did a real good job explaining the difference between orals and IVs, but we just had a quick question. Are you sure that there's a maximum amount of pocket with injectables? And if so, how is that determined?
For commercial plans, there is typically, yes, a maximum out-of-pocket. So once the patient has met that out-of-pocket, then they may continue to have a small copay. In many cases, they do not.
I'll ask you to
just... Does that answer that question, Don?
Yeah, I think so. And we just got a couple more here, and then we want to get allow time for Trish, too. So.
Right. So in our practice, each patient is going to meet with a social worker to do a needs assessment. That can be financial or emotional, and it's in many cases, the need for financial assistance is obvious within that very first visit. The patient can be uninsured, they may be disabled, they may no longer be able to work because of their illness. So following that visit, our patients meet with a patient finance coordinator, and that's the person who actually sits with the patient, reviews the cost of their care, and then explains to the patient what his or her cost is going to be. And typically, this is where patients with insurance will realize that they're going to need some form of assistance, and then that starts the ball rolling. And at any point in the process, a conversation may take place with the patient's oncologist if it seems that the cost is going to be an insurmountable issue for the patient. And so therapies change, or the patient agrees to an IV therapy, perhaps, rather than an oral therapy. And as I mentioned earlier, the charity care program that we have certainly benefits patients, because in other practices without that, they may be considered bad debt. So
I think you answered one of the... Go ahead.
The final slide is just showing you the work that we've done in the first 6 months of the year. If somebody can advance that slide for me. Mine don't seem to be advancing. Okay. So in the first 6 months of the year, we saw over 5,000 patients. We helped more than 200 patients enroll in insurance programs. Could be the exchange programs or Medicaid, Medi-Cal. Almost 100 patients received financial support for transportation. Almost $400,000 obtained in free drugs. Almost $300,000 in copay assistance awards, and we have another 100 patients enrolled in copay card programs. So I think we're at a point where finding assistance for patients has become an absolute necessity for oncology practices. New drugs coming into the market are carrying an average price tag of $100,000, and we can't assume any longer that patients can afford to pay their share for their care. And another consideration that will not be lost on practice managers in the office is that by utilizing patient assistance programs, we're actually reducing the possibility of bad debt when we're treating patients who ultimately would not be able to afford the cost of their care. So I think it's really critical that we provide the resources within the practice to make those conversations happen and help the patient as much as we are able to do so.
Lynn, thank you very much. I wish we had a little more time, because there are a few more questions to ask, and maybe we can get to them at the end, but I certainly want to get Trish on here. Trish, it's always tough going last. So if you would, though, please, Trish, your perspective. I think a lot of people may recognize your name from your role at NCCN. Real quick, could you tell us, give us a quick little history, and then let's hear what you're doing now today as CEO at Cancer Care.
Certainly. Thank you, Don. So for those of you that know me, I started my oncology career by spending 10 years at Moffitt Cancer Center in a senior leadership role in a variety of positions. And from there, I went to representing one great cancer center to 21 great cancer centers in my role as Executive Vice President and Chief Operating Officer at NCCN, where I was for 8.5 years. I am now entering my 8th month of tenure as the CEO of Cancer Care, which is an organization that is 71 years old and 4 locations, Manhattan being the corporate headquarters, then New Jersey, Long Island, and Connecticut regional offices. And here I am basically responsible for not only the oversight of the entire organization, but development and execution of our policy agenda, national branding, and I joined slightly over 100 other employees, including about 37 master's prepared oncology social workers in that vision.
Excellent, excellent. And can you advance your own slides? Is that
I believe that I
for you?
can.
Yeah, there we go.
I
Good.
can.
Okay.
So I just want to touch a little bit on some things that you probably already know, but really have been put in context for me as I have spent my time here at Cancer Care, where we are talking every day to hundreds of individuals who have faced or have faced a diagnosis of cancer. Clearly, with 4,500 new diagnoses each day, it is a major, major issue for individuals. Overwhelmingly, we see that patients have a tremendous amount of fear and anxiety, as do their caregivers, as do their children. Fear and anxiety in many different ways. Certainly, the increasingly complex treatment modalities and therapies that patients are facing, while wonderful and wonderful advances, can become extremely confusing to them in terms of treatment choices and options. But that's also coupled with insurer rules and regulations that for many are not clear, confusing, and sometimes downright onerous. The concept of in-network and out-of-network, particularly acute as networks are narrowing, co-pays that patients had no idea that they would be facing, deductibles. About 40% of individuals that have enrolled in the ACA do not even know what their deductible is. And then I call it tier shock, and that is the tiers in formularies and the shock that patients face in terms of their out-of-pocket dollars, which are simply unmanageable for them. Then there is the shift of community practices being acquired by hospitals and the change in reimbursement and the change in cost to patients. So amid all this, we often hear many key opinion leaders calling for patient-centered care and greater patient engagement. That all sounds really wonderful. Clearly, we all wish for effective and productive physician and patient communication. Decisions should be shared with respect to care, and we all want patients to be more involved in their care. The problem is, right now, the only thing that I see that is really driving patient engagement is by making patients pay more. And that is not my definition of engagement, and I think that's extraordinarily problematic, but also represents an opportunity for us to define better what patient engagement really is. Patients want involvement. This is from the 2013 IOM report on delivering high-quality cancer care. But what's really important to me about this slide is if you take a look at the first 5 bars, we're essentially talking about time, a physician's time to talk about treatment options, treatment goals. Often there is a lack of comfort among patients and even their caregivers about having these discussions. And quite frankly, there isn't enough time for physicians, and as it relates to understanding the cost and how much option will cost each particular patient, physicians are not prepared often, nor do they have the information to be able to engage in those discussions. And I think there is a real discomfort on the part of many patients in actually talking about cost for fear of the potential consequences it will mean with respect to that dialogue with their physicians. So Cancer Care serves approximately 170,000 clients per year in about 92% of the counties in the United States. So what are some of the things that we are hearing? We do hear that patients want to have some participation in their treatment decisions. They want their priorities and their values to be reflected, but that is very, very difficult for patients to communicate. There's not good tools out there, and we also find out that many elderly patients just don't have the comfort level of engaging in those kinds of discussions because they've been trained that their physician always knows best. We also increasingly are hearing patients tell us that when they attempt to engage in discussions with about these kinds of issues or different treatment options, often they're hearing from their clinician, that's not for you. And that's about all they're hearing. Also, how to discuss with the clinical team the cost. And cost is, I think we focus so much, for obvious reasons, on out-of-pocket costs related to drugs and biologics. But there are so many different costs that are involved in cancer care that are difficult for patients to discuss, and oftentimes they're not even aware of them as they're making treatment decisions. Transportation costs, parking costs, the cost of being able to have individuals provide for child care while they undergo their treatment. So there are a lot of barriers that are not just insurance related or not just related to the actual benefit design for drugs and biologics. Also, patients are increasingly facing complex pre-certification requirements that are a resurgence that are very, very challenging when you're just trying to get through the diagnosis, care for your family, work, and also be able to afford your care. But I think it's really important to emphasize that these financial barriers are very, very broad. We see patients every day that are unable to complete their treatment or complete their clinical trial because they don't have enough money for transportation or parking. Money for child care, house cleaning if they're not able to do so, meals, and basic living expenses. So I think it's really important to understand that the medical costs are very, very clearly at the forefront, but there are a lot of other wraparound costs that are challenges for patients that are real barriers to adherence or completion of their treatment. In addition, quality of life issues are so important for patients. The ability to work, the ability to feel productive, to care for their family, and the little things that can make such a big difference to them as they go through their cancer journey. What are our challenges in providing financial support to patients? What we're finding is that there is an ever-growing need for many types of financial support. Certainly, co-pays, the drugs and biologics are very key, but there's also requests for COBRA funding, hospital bills, food, and so many others. And then I think there is an increasing lack of understanding about the complexity of their benefit plans and actually how to navigate through that to really understand what their out-of-pocket costs are. For individuals who've had a health plan and have been fairly well and perhaps on a few prescription medications that cost $15 or $20 a month in terms of copay, there's absolute shock when they are prescribed an oral and they find that potentially their copay is 20, 30, or even 40% of that medication. For us, having a separate corporate entity that is one of about 8 recognized copay organizations within the country, we are definitely operating in a heightened regulatory environment, which makes it ever more challenging to help our patients. The OIG issues various opinions about the operations and the guidance. As an example, right now there is some discussion about whether or not there can actually be copay funds for patients in the metastatic setting. So it is a very regulated, with a great deal of oversight, environment that takes a lot of time and effort and resources with respect to reporting. It's also frustrating to me, and I think to my organization, that it's very difficult to highlight the good work and the contributions from industry. There are so many companies out there that provide valuable support, whether that is for transportation, drug copays, or child care, that make it possible for an individual to complete their treatment. Yet this heightened environment and scrutiny makes it very difficult to recognize the good contributions from industry, and we would certainly like to acknowledge that. We also have
probably like to see more of it too, right?
Absolutely. I'm getting there, Don. And it really is sometimes there are increasing burdens with respect to reporting from funders. I think when you've seen the reporting requirements from one funder, you've seen them from one funder. And so it does take a great deal of time and effort to report and forecast on the multiple millions of dollars that are being distributed to patients. But I do have to say that, in my opinion, there is far too much focus on the cost of drugs and biologics. It's not just that. There are so many other cost factors in the delivery of cancer care, and quite frankly, I think that the drugs and biologics have become somewhat of an unfair lightning rod, just my opinion. Yes, it's definitely an issue, but we see patients struggle with many other components of affordability that are not just related to the drugs and biologics, and we see that each day.
Interesting viewpoint, Trish. I just want to add, it's almost the end of the hour, and we welcome you all to stay on. We're not going anywhere right now, but I will say that one of the major questions is, will the slides be available? We're archiving this, and we'll make the archive available, so you'll be able to hear and see the slides again shortly after completion of this event. Go ahead, Trish. Sorry to interrupt.
And this slide is just intended to illustrate a representative calendar year with respect to the copay. This is, again, only in the drug and biologic space. We support patients with many other millions of dollars in the non-copay space. I think the takeaway here for everyone, though, is to say that there are many other needs. You do not see every disease represented on this grid. In fact, there's a total absence of funding for some diseases where the need is great. And so my message here is that more funding is going to help more patients in so many different ways. And lastly, in terms of how we can collaborate, I will tell you that I think patients are in desperate need of credible and practical information that really meets them where they are. Information related to pathways, as an example, information related to network access, understandable information related to therapy advances and the importance of that. And I think, speaking to the last slide, broad financial support for all illness-related costs. This is an acute need for individuals to access and complete their treatment. And I think that greater transparency is important for individuals in terms of barriers to getting best care. Transparency related to insurer-mandated pathways. I think that advocacy can be a great resource for manufacturers in this issue. It's interesting to me that there is a perception that perhaps giving a clinician a pen could give undue influence, and yet there are $350 a month payments being made to clinicians for adherence to pathways. I don't think there's enough transparency about that, or even a mechanism for patients to have a dialogue about that. And when I say bringing the patient voice to the center of the dialogue, one of the areas where I think there is an absolute deficit with respect to that is in the discussions that are occurring surrounding value and the definition of value in cancer care. I think there's an absence of the patient voice and a lack of understanding of the patient's voice in terms of defining value. And I think we need to find ways to support patient activism and engagement. I don't think patients are terribly engaged, and once they want to be, they're often faced with so many other overwhelming issues with respect to affordability, access, just being able to feed their family and work, that it's very difficult. Early activism, I think, is important, and greater psychosocial support. We see this every day in terms of the difference that we can make with respect to ensuring treatment compliance and their quality of life. And so, Don, I will stop there.
Trish, I can certainly see your perspective has changed along with your new role at Cancer Care, so thank you for that. We're, like I said, out of time, but let's just take 2 more minutes, if I could. We have a couple questions that haven't been answered. There's been a lot of chat going on. I can see panelists answering some of the audience members' questions directly, which has been effective and helpful. Thank you. Trish, you emphasized the manufacturer, or you called it industry support, and how well that is, or how good that is, I guess. And then I'll dovetail that with Lynn. Lynn, may I ask, do you feel the same way? Are there more things that industry could be doing to help your practice in particular? Do you have any thoughts on that?
I do. We're very fortunate in having programs available to us through pharma, but as I think about your question, certainly continuing education to our staff who manages that process is very important. I just returned from a meeting sponsored by pharma and learned that their particular drug would be provided free of cost to our patients if the patient had been covered by a foundation that subsequently lost funding or had run out of funds. That was something that was unknown to our staff. So that was important information. I think they could do a lot for us in terms of community outreach, such as senior programs or presentations to low-income clinics. And for those patients that are newly insured through health exchange programs, these are people who have been previously uninsured for the most part. So they really don't have a good understanding of available programs and what might be available to them. So I think those are probably 2 key areas in which our practice might benefit.
Yeah, you didn't have to hesitate for a moment. You knew right away. Trish, a quick one is the pattern of requests for financial assistance from parents with children in cancer treatment similar to that as seen in adults?
We certainly serve parents and their children. I can't say that I have any data to suggest that there is a noticeable difference. We do have very active programs for parents and for children here at Cancer Care, but there's no data that I can really share, Don.
Mm-hmm. Okay. While I have you at the podium, you mentioned that OIG would possibly not support funding for metastatic patients.
So there's been a lot of activity in the copay space and some recent activity from the OIG just clarifying with respect to the types of funds and, shall we say, the transactions and the relationships between the copay foundations and the manufacturers. And there has been discussion about the fact that metastatic may be too narrow of a category with respect to funding. I don't think that has been clarified yet, but that there are metastatic funds that do exist, and I think that there's not yet quite an understanding of where that will go in the future.
Okay. And challenges, you mentioned, and you elaborated on this, or you spoke to it, but maybe I'll just ask you to elaborate on it. What are on behalf of the broader community of advocacy organizations and copay foundations that are helping all these cancer patients, what are the key challenges that they are facing? Is there anything you want to elaborate on there?
I think the greatest challenge is certainly the lack of funds and lack of resources. And this particularly becomes true not just in the copay space, but there are a number of advocacy or other organizations that have provided financial support for individuals that no longer do so. And so it's just a matter of finding the right funds for the right individuals. I don't think that there's necessarily enough funding for men. Many of the funds are focused toward women, and this is particularly so, I think, when you're talking about some of the transportation assistance and other types of care. And then I think it's just making sure that we have all the complex administrative functions in place to be able to get patients the help and the therapy and the financial support and psychosocial support that they need, Don. So it's just, money doesn't solve everything, but in this case, it solves a lot for some money. I can't tell you how many letters I get from patients saying the $300 that you gave me made the difference between being able to complete my clinical trial or complete my therapy because I could afford the gasoline. Often that's overlooked.
Well said, Trish. Debbie, I'd like to ask you, your study clearly established that patient affordability is impacting on prescribing. And I think this is the first time you've shown this study from Kantar Health. Are you going to continue your research in this area so that we have sort of a baseline now and we can continue to track this?
Oh, absolutely. We've been trending this research for going on 4 years now. We do on occasion update the questions to better reflect what the situation is. So in some cases I don't have the trended data showing, but absolutely. And we'll be starting to put our 2015 research in the field in the February through May timeframe is when it will all be fielded.
So for everybody out there, stay tuned, I think, is the answer. And we're about 10 minutes over, so I'd like to, again, mention that this will be archived, and as a participant, you'll be alerted when the archive is available. The contact information is available here on this slide, too. Our panelists told us beforehand they're welcome to answer any questions that you might have additionally. Debbie, thank you very much for your work, hard work, and the support of Kantar Health to put this on. And Lynn, thank you again for preparing and getting ready and participating in this, and the same thing to you, Trish. Great thank you for your participation today.
Thank you.
You're more than welcome.
Great. Thank you all.
I'll look forward to our next one. Thank you very much.
Ladies and gentlemen, that does conclude the webinar for today. We thank you for your participation and ask that you please disconnect.